Walter, sasa?
Hey.
Hey, how are you?
Hey, Judy, sasa?
Niko mzuri.
I don't know, I can't hear you. Can you hear me?
Yeah.
I cannot hear you. I don't know why. Is it my... Let me check. Oh, yeah. I can hear you now.
Yeah, how are you?
I'm good. Long time.
Yeah, you still look good though.
Oh, my...
But that's good. I get a break today. I just wanted to make sure that you get started, okay?
Yeah, thanks. It has been busy, but, you know, we're hanging in there. Yeah.
Good.
How is that going? I saw you got a nice job somewhere in, I don't know, NIH or something. And
yeah, we will.
I see some of your videos, man, on YouTube. I'm like, what? What are you teaching? You know, I can't understand.
I keep the fire going till you're ready to come back. But
That's
I
really
understand.
good.
It's good.
Yeah.
So this is now we started doing this thing. I see Dr. Newsom joined in as an attendee, but
Nice.
yeah. But
that's okay.
That's okay. Yeah.
I know it has been stormy, like the way we're conducting these things. It has been like we're not getting many people come on board. Volunteer or something.
Yeah.
Yeah. There's one doctor.
I think we just have to look. Huh?
Yes.
You just have to ask people specifically.
Yeah, I asked specific Miriam. She's a surgeon, I think, in Wisconsin.
Oh wow, that would be cool.
I don't know if you know her.
No.
So I think she studied in Kenya. I was following. She was from Arizona. She wants to help, and she's an endocrinology surgeon. So
wow, that would be great.
She wanted to know how much we have covered, and she wanted to really help. So
okay, so why don't we can plan to talk about that, me and you, but not right now.
That sounds like a plan. I know we're busy. Sometimes creating time, it's like.
Oh yeah, no. It's because actually, we're doing this new thing. I don't know if you can see. So it's like a live stream, so people can just join with the list. So I figured that we can just talk about that offline. Yes.
That's awesome.
So
I like that.
Yeah. So you can see that. So it's pretty easy. Where is the link?
Oh, on YouTube Live. Oh, I used to see people do that, but I don't know how they do it. I'm so bad in technology. I was thinking maybe I should upgrade my technology anytime soon, at least a little bit.
Yes, you should. Yes, you should, and you should not be struggling without me. So that if you click on that link, you can just see yourself live. It's
nice.
Easy.
Hello. Good morning, everyone.
Good morning, Dr. Newsom.
Hi, how are you?
We're good.
To see you. It's good to see you, Dr. Gichoya. It's good to see you as well.
Thank you.
I'm looking forward to this talk today, and I've cleared my head so that I could just get it all. Whatever it is that you're going to be dropping the knowledge today, that it's going to be filling it up. Also,
more sharing the knowledge.
More sharing knowledge. Okay, but maybe we're using different law, diffusion, going from an area of highest concentration to an area of lower concentration. So
sometimes, yeah.
Okay, Janice, hallelujah. Stop.
Okay.
I see we have a couple of people already. 4 attendees. So we have 3 panelists. So
it's gonna go up. It's gonna go up.
Yeah.
I would give them like maybe
2 minutes.
3 or 4 more minutes. Yeah, it's gonna go.
We don't want to stay. We don't want to wait for long. I think we can start as soon as possible.
Okay.
Yeah. So Miriam,
hey, morning, Tanak.
So she's sending me a message. She's saying, so I was requesting her to teach endocrine physiology and pathology. She's an endocrine surgeon. And she's saying she wants to know I don't know how I can get it. Are you able to send me that link? The one you just posted?
Oh, you want
I'm not sure
it
how
on
I can get it on my phone. Yeah, WhatsApp or something. So she's asking when she can come in and do this.
You can come after your 2 weeks. We're gonna take advantage of you being here for 2 weeks.
Yeah, I'm here this weekend and next weekend. I have a lot of resources. Actually, I got these resources from medical students.
What?
Who are here. Yep. So I was like, maybe that's the right information to do. But
that's
so
good.
I don't know.
Did you
Let me
get
know when we're ready.
No, it's
Let me just
10. It needs like 2 more minutes.
Yeah, I'm gonna mute. I talked to Miriam for a short period of time.
And then you'll come back and after your call, just get started. Good morning, everyone. We are going to give people just a few minutes and then we will get started. I hope everyone is doing okay. And I know you want some music. Morning, Irene. Thanks for joining. Morning, Sean.
Tell me something where I know fit do. My love too. I hope you're ready, cause we gonna move. Feeling the boy, feeling the boy, feeling the boy, feeling the boy, feeling the boy. Okay, I'm so interesting. It's why they say that I'm the next thing. So even on features, I'm impressing. Do my flexing. Yeah, I learned a lesson. They throw me shots, but I am a chesting. I'm far from pop, my pop is resting. I flow so bad, my tongue is vexing. Yeah, no one is testing. I'm best by far is what I'm guessing. 1, 2, 3, I win like wrestling. How can I lose? I'm with the best team. Yeah, I'm the boy with the fire. DJs give me more speed than a tire. Seen it all, sang in the choir. Feeling like I'm tunnel here, only go higher. Yeah. Tell me something where I know fit do.
Thanks, Varad. Okay, so it appears Walter is ready to get started. Welcome, everyone. For those who haven't met Walter, he really is the brainchild of this project. Yeah. So, you know.
Hello?
Yes, we can hear you.
Yeah.
Take it away. So remember, we have quite some students actually from Rwanda now.
Oh, nice.
And
that's awesome.
And some from Tanzania. So, and our favorite ones from Kenya. Anyway, everyone is our favorite, but
yeah, my favorite ones maybe from Rwanda. I don't know. I don't know that. I'm just picking up a country. Yep. Anyway.
Yeah.
So welcome, guys. My name is Mogeni. I'm going to put my presentation up. I think we used these PowerPoints last time and we stopped somewhere. So I'm gonna start today. I'm gonna teach a little bit about psychiatry, talk more about it. I will try to be as fast as possible. I know a couple of you are doing exams, so you might need to, you want things to be run fast. and furious. If I'm so fast, please let me know so that I slow down my speed. I hope you can see my slide. Let me try to make it like a PowerPoint slide. Okay.
Yes, we can see. We can see.
Thank you. So I know we went through all these amphetamines and all those substances. Last time I was presenting, we went through personality disorders. I hope you remember. And I really don't want to go through this today because as you know, initially we sent out some, you know, whatever we want to cover today. And it was more of paraphilic disorders, things to do with what?
Close your document recovery on the left. Dr. Walter, please do not catch Dr. Newsom's IT disease. So close on the left side. It looks like your PowerPoint crashed. Close that
really?
and then start again. Just scroll.
So just close it?
Yeah, unless you already have your files there.
I have my files.
And we cannot see you. Yeah, you need to share the screen again.
Yeah, I'm gonna do that.
And then yeah.
Happened to me.
I hope you didn't lose your score.
I may have lost my stuff. This will be a shocker to me.
This would be really bad.
Yeah, but I have other resources to use today because I have so many resources. Actually, yeah. I kind of lost everything, but anyway. That's okay. So guys, I'm gonna talk about paraphilic disorders shortly. Let me just share this. But I have other resources to use, so I'm not worried at all.
That's the final word of today. Always be prepared. Yeah,
something can happen. Yeah.
Later on, just yeah, I'm sorry.
Yeah, I'll try look through that later. So I'm sorry for that, but it seems like I don't know what I clicked. I don't know whether I saved my slides, but anyway, there were not so many. There were like 20 slides, and basically, can you see my slides?
Yes.
So this is where I stopped, and I continued from here, but you know what? I wasn't able to have my slides on anyway, and I don't want to dig deep into that right now because we're going to be wasting time. So let's talk about these disorders. Anybody who knows what is voyeuristic disorder? Are they able to type in? So
yes. Are you able to see the comments? Bernard said peeping.
Yep. So so when this is basically those people who have a habit. So in psychiatry, we have timelines. So that's number one. You should think about time. How long will this take? How long do they do this for that to be a disorder? Does it cause socio-occupational dysfunction? Those are the things you're looking at. Is it like impairing them to do whatever they need to do? So these people try to sneak a peek to unsuspecting, somebody who is not consenting to their sneaking a peek, and they tend to have arousal, sexual arousal through that. So they peep on somebody and they see if they're naked, and that's becomes a disorder if it's consistent for over 6 months. And there is obviously some impairment, social impairment. So exhibitionist disorder is like more of, if you go out there and exhibit your stuff, you know, so like you're selling some things, but these people kind of go to the public, to unsuspecting people, and they, you know, show off their sexual organs, and that tends to make them feel, you know, they're sexually aroused, and they kind of enjoy that. But that kind of makes them to socially, they really thinking about doing these things all the time, they get socially impaired and dysfunctional, and usually 6 months of a history of doing that. So Frotteuristic disorders is basically using some others, like maybe not around the genitals, but they are using other organs to make them feel like maybe clothings. They see some clothing, they see some other objects, and they think of they become aroused sexually, and they are not able to function in the community. Masochism basically means somebody who enjoys creating some pain to other people, and that's kind of, they get aroused when those people get sorry, that's sexual sadism. So sadism, there are two things here. Sorry, let me not confuse those two. So sexual masochism and sexual sadism disorders, those are two different things, and I don't have that in my slide. But sadism is whereby you try to create pain to somebody else, and that tends to make you feel good. But masochism is like you are the recipient of these acts, and you tend to enjoy them that way. Okay. So I'll encourage you to go and look at the other points of these slides: fetishistic, transvestic disorders. So fetishistic, sorry, let me apologize. Let me just draw back what I just said. In terms of frotteuristic, is those people who want to come to you and you know, be close to you without your consent, and they tend to touch you inappropriately, rub themselves against you. That's frotteuristic. Okay. Fetishistic, they start with F, so I'm sorry for that. So fetishistic is basically where they use other substances like clothing and stuff like that for them to feel the sexual arousal and stuff. And all these things tends to be disturbing enough to cause some discomfort at their social occupation. There are other things like coprophilia. You know, coprophilia is where they use feces to coprophilic disorder. They use feces, and they tend to, you know, tend to get pleasure out of that. Necrophilia is where they use corpses. Necro for necrosis. Okay, so they used to use corpses for them to get that sexual arousal, and but they get socially dysfunctional. There are other things like catalogy. There's some, like, for example, people use a phone a lot, and there's another terms for that. So I'll highly encourage you to look into that. But now that I lost my PowerPoint, I'm gonna go ahead and share this quick so that it helps me to teach, and I don't want to say something different that I wasn't planning to. So let's go share this. I'm not sure if you can see this, guys. Judy, can you tell me if you can see this?
Yes.
Yeah, so I got all this documentation. I have a number of question bank we can use, and this will help us take care of the mood disorders, and also take care of other things in terms of revision, in terms of how you're gonna attack some questions during this exam period for some of you. So basically, we're going to look at some tests and see whether you really need sometimes to read all the questions to answer this question. You need to read the entire clinical veneer. And because of that, before we start looking at case number 1, I want us to look at the questions. So question number 1 says, and maybe look at the last part of this question. Before you answer any question, I'll highly appreciate if it's a very long clinical veneer. Sometimes you really don't need to look through the entire question, depending on which kind of questions they ask you down there. So if we look at the last part, on examination in the clinic, she's extremely talkative, laughing, spontaneously making fun of things that came into her field of view. She has dark circles under her eyes, but is very active and gesticulates wildly. She denies suicidal or homicidal ideation and shows you the list of things that she has to get done today, asking for you to hurry up the evaluation. And she says, I have places to go, things to do. So if you read the last part, and start answering these questions. Based on history and physical exam, what is the most appropriate immediate intervention for this patient? You know, I don't want you to answer that question. Let's look at the second one. Other tools for managing her agitation include all the following except. So, then the number 3, they are asking you what is the diagnosis, okay? So sometimes you don't need, this maybe might be one of those questions that if you look at the last part of this question, you know, you have an idea what's going on. Let's go see how the clinical veneer how much information we can get from the upper part. So a 38-year-old widow is being evaluated in the clinic exactly 3 weeks after the death of the husband in a railroad crossing accident. Apparently, she had been driving the car and stopped short of the train tracks, but was pushed onto the tracks by a moving car behind her. The car stalled and her husband was unable to get out of the car in time. Although she did escape without injury, for the first few days after the accident, she was described by her friends as numb and in a state of shock. However, by the time of the funeral, she had become more spontaneous and shortly thereafter began behaving erratically. She bought a new car, so remember that, to replace the one that had been wrecked and drove it so recklessly that her friends and neighbors became alarmed. She also bought a new tractor, a truck, and implements for the tractor. She bought furniture, not only for her own family, but also for a neighbor, and ordered a freezer for her sister. She had been calling people at early morning hours and is noted to be very irritable with her children, at one point striking her 6-year-old, and at another throwing a knife across the room when her children were too rambunctious. At that time, she's giddy and silly, talking about looking for a new and improved husband. So on examination, we talked about this: hyper talkative, laughing a lot, spontaneously making fun. There's some circles under the eyes, but it's very active and gesticulates. And she said, hurry up, I have places to go and things to do. So based on the history and the examination, what is the most appropriate immediate intervention for this patient? Do we have responses already?
Not yet. Maybe you may want to focus on the question so that the number 1.
Okay. I just push it up. Can you see it that way?
Yeah.
Yes.
Okay, so the first one is hospitalization. And guys, you can just say A or B.
Yep.
Hospitalization.
Okay. What about any other different answer? No. So yeah, you're right. So the first thing you want to do is hospitalize this patient, even if it's involuntary, but you want to tell them, like, you have this problem and we don't think you can make the right decisions, okay? So what about number 2? Physical restraints. You do not do restraints when patients you haven't talked to them. They are not really doing anything, agitation or harming anyone. They are not harmful to themselves or harming any other person around them. So risperidone and lorazepam. I mean, we don't have any reason at the moment to give those medications. When people are very agitated and stuff, sometimes we use lorazepam. There's something called B52. Like we have Benadryl, we give haloperidol, and we give lorazepam. It's like an agitation kind of concoction that we do give. But at the same time, you can give risperidone for severe agitation. I'm okay with that, and maybe sometimes with lorazepam. Valium tolerance test. I don't know why you should do a tolerance test to this patient at this point. Careful social and family history. That is helpful, but that's not the immediate intervention. Underline the word immediate. So other tools for managing her agitation include all of the following, except removing items from the room that the patient, continue answering if you read faster. Removing items from the room that the patient could use as a weapon, addressing the patient by her first name as a sign of familiarity and accessibility, avoid sustained direct eye contact. I'm gonna push this high. If you don't see it, Judy, remind me to just push it up for people to see. Avoiding sustained direct eye contact, asking the patient if there is anything you can do to make her more comfortable, allowing both you and the patient an escape route from the room. What are people saying? I can't see, so I hope.
B, D.
B and D. Anything else, please?
And E. Boy, dog, elephant.
Yeah. So anybody else? Remember, there's nothing wrong here. It's all about like, how do you think about this question? So remember, other tools for managing her agitation include all the following, except we're looking for the wrong one here. So 4 out of 5 should be correct. So the only one that is different. So removing items from the room that the patient could use as a weapon, that absolutely the safety of this patient, okay? What about addressing the patient by her first name as a sign of familiarity and accessibility? So in the US medicine, the most important name to use is the last name, unless the patient tells you they prefer the first name. So usually we go by the last name, unless there's any, I don't know how Janice and Dr. Judy, you have been using those words, but that tends to be a wrong answer at the moment. It's not the right answer. Avoiding sustained direct eye contact. If the patient is aggressive, agitated, you don't want to go there and start looking directly into their eyes as if you're confronting them. So, and asking the patient if there is anything you can do to make her more comfortable. That's a question every clinician should be asking. Is there anything I can do for you to make you comfortable, make you feel better? Allowing both of you and the patient an escape route from the room. Exactly. You know, whenever you are with a patient, especially in psychiatry, who are agitated, they can kick you, they can knock you. Sometimes some patients will do that. You want to stay near the door, near an escape route, you know, so that you can get out. Even the patient, if you can create some room for them, if they want to move out or anything, you're not restraining them. You know, restraining is different. You want to give that room for them to do that. But at the same time, safety comes first, especially you as a clinician. So this is a typical question that you get when you really doing these questions. And these are questions that come for the exam, the USMLE exams. You have to be very careful, especially when they say except. Please underline that word and know that most of them will be correct. So B is the most likely answer right now. Yeah, that's okay. I mean, the thing is, yes, that's what I'm trying to emphasize, that sometimes when you read this question, there's one trick maybe in between that might turn you wrong, okay? And maybe you're in a hurry to finish up the questions. All right, let me go to question number 3. After appropriate steps, the patient is hospitalized in a psych unit, which is the best thing to do for this patient. Further history from the patient and family indicates no previous history of mood symptoms. Given the information to this patient, what is the patient's most likely diagnosis? I would like to see what people say. And maybe I will try to elaborate more about this. What is your answers?
There's B.
Mm-hmm.
Someone says, remind us of the timeline. Hey, Walter, do you have a second monitor? I can help you if you could trust me before I lost your slides. How to see the comments? Are you able to see the comment?
I'm able to see the comments actually now.
Oh, okay.
Yeah. So anyway, remind me of the timelines, please. I'm not sure which timelines you're talking about, but are you talking about I will tackle this question, then I'll talk about the timelines in terms of mood disorders, like if you're talking about whichever answer you choose. Okay. Okay. I will try see what I can do. Any different answer? Oh, I remind you of the timelines from the question. Okay. I see. I don't remember 2, but I think it was like 2 weeks, 3 weeks. Let me see. Question number 3. That's a good question, actually. So evaluating exactly 3 weeks after the death of the husband. So it's almost 3 weeks there. Okay, that's a good question to narrow down your answer. Any other answers? So bipolar, that's what I saw. Anything else? B, I think that's adjustment disorder. So let's talk about this. I don't know if you guys know this mnemonic by the name DIG fast, DIG fast. So DIG fast stands for DIGFAST. I may not remember the entire thing, how it stands for, but distractible, if you are easily distractible. If you have indiscretions, indiscretions is like you are hypersexual, that's for I. You may be doing some, hypersexuality and risky behaviors, those are indiscretions. G is for grandiosity, you think like you'll conquer the world, you're on top of the world, okay? F is for flight of ideas. This patient is talking about like he has many things to do, he wants to go somewhere and all those kind of stuff, okay? So A, I don't remember what A stands for, but sleep is reduced. You see, this patient was this patient calling early in the morning and stuff like that? If you remember that, let me just go back to the clinical veneer a little bit. So if you look at the last part here, they say talkative, laughing and spontaneous, making fun of things and all that. At this point was denying suicidal, but if we go a little bit up higher, so they say she was buying so many things, that's impulsive behavior. So buying so many things, spending a lot of money, that's part of what we have in the, if you're thinking of bipolar disorder, okay? Recklessly, they said that she bought a new car to replace one that has been wrecked and drove it so reckless, she was buying a new tractor, bought furniture, and she was giving people. She was calling early morning. So early morning is where I brought that point of S, sleep. Sleep will be highly reduced in these patients, okay? So with that being said, this patient, looks like a bipolar disorder, okay? And I tend to agree with some of you who said bipolar affective disorder type 1 at this point in question number 3. So let us look at the other parts. Complicated bereavement. So complicated bereavement, yes, it can be a possibility, but it's more of suicidal ideations when you have complicated bereavement. Adjustment disorder with disturbance of mood and conduct. Actually, that's kind of the second best answer if I didn't have bipolar. But the moment you get one diagnosis meets the criteria, for example, bipolar disorder. And this is the thing you should remember. For bipolar, the mood has to have changed for more than a week because they meet those criteria. They have distractible, this person is spending a lot of money, is sleeping less, is hyper talkative. That's kind of what this patient is. What do you need for you to say that the patient is manic? So this is a manic patient, At this point, the patient is agitated. What do you need? What is the criteria from DSM-5? DSM-5 basically tells you need to have these symptoms for 1 week, That's why I think one of you was asking about the timelines. So at least 1 week of these symptoms, okay? A for agitation. Thank you, Bernard. So that's the other thing. So the adjustment disorder, if this patient was not meeting the criteria for bipolar disorder, maybe I'll have gone to adjustment disorder, okay? Brief psychotic disorder, like brief psychotic disorder, usually it's less than 1 month, that's for sure. And nobody said that. We don't have any psychosis. We don't have any hallucinations, delusions, or anything like that for us to talk about psychosis at this point. So let's look at question number 4. Question number 4. The patient is started on BZs, benzodiazepine, at bedtime and does begin getting some sleep over the next 5 days. She becomes progressively dysphoric, beginning to have some insight into her recent inappropriate behavior. She feels that she will never be able to live down the fact that she had appeared happy after her husband's death. She is tearful, guilt-ridden, slowed, and wishing to die. At times, she hears her husband talking to her and telling her that she should join him in death. Considering this new information, her most likely diagnosis at this time is, guys, go, please, give me the answers. Give me the answers. How many people do we have? I think we have many people, 24. So 20 at least. That's a good number. I need more answers, please. I know this question might be challenging. Okay. I see B, adjustment disorder. I see A as complicated bereavement. I see major depressive. I don't see major depressive disorder there, which is good. So this is a very tricky question, actually. So guys, the moment, you know, if you talk about bipolar disorder type 1 or type 2, you know, type 1, it's whereby you have manic episodes. Actually, some people call type 1 mania. That's period. But it has some moments of depression with it. Type 2, it's more of hypomanic, you know, if you remember that, bipolar affective disorder type 2. It's more of hypomanic, but more of the depression side, you know. And type 2, for this patient came with mania. And if we agree that this patient was manic, then the answer cannot be E, okay? The best answer for this case is D, bipolar affective disorder type 1. Reason being, because I think the contentious point is whether you should go for D or E, okay? And that's a good school of thought to have. But remember, for type 2 bipolar disorder, you just have some hypomania, okay? And hypomania, usually it's up to 4 days, like, of symptoms. And usually patients kind of, you know, just have some few symptoms. They are not superman. They don't have all these features of mania, and they tend to have be more on the depressive side than anything else. So does this fit to be a major depressive disorder? No, it cannot be major depressive disorder because it cannot be major depressive disorder because of what? Already the patient met a criteria for another condition, which is bipolar. And that's why some psychiatry can be confusing. Sometimes you think you got it, and sometimes you're like, oh, okay, I got these points. This is how it goes. But they can be confusing, and you need to take this seriously for your USMLE. So if you meet a criteria for bipolar disorder, there's no way you can have a major depressive disorder, okay? So, of course, the same thing, A, B, and C, if you met a criteria for another disease, there's no way you can go back to another, you know, diagnosis, okay? Because if I had only symptoms for depression, I'll go for major depression. I'll not think about bipolar, for example, okay? So I think I can move on unless there's a question somewhere out there. And the other thing that you should underline about this question 4, the second last line, at times she hears her husband talking to her and telling her that she should join him in death. So what do you think about that? Is that psychosis? Any quick comment? So usually you can have this kind of, most people who lose their loved ones, they can have this symptom, like they hear, it's like they're talking to them. It might be maybe a form of psychosis, but that tends to be normal thing. If you see a question and they're talking about grief, maybe we should look for some time we talk about grief and bereavements, And these patients tend to hear that, and you should not be super worried. You tell them, you know, you might hear them talk to you for some time, and this is usually normal. Exactly, Bernard, the way you just said it. It's normal so long as it's less than 12 months. I didn't know about the timelines, to be honest, but I thought it's normal that way. Okay, those are two points you should carry for this discussion. Remember, those are normal in terms of grief. And remember that bipolar disorder is basically mania, and less of depression might be there, but mostly the patient presents. The whole clinical vignette we were talking of mania, actually. So let's go to question number 5. I'm trying to hurry up, but I hope I'm not too slow to some of you. The patient continues to deteriorate. She begins banging her head against the walls and throwing herself on the floor, calling out for God to deliver her from living any longer. She's wrapping sheets around her neck and scratching at her eyes, requiring restraints. The team decides to offer the patient ECT. Which of the following is the strongest contraindication to use of ECT? Please, guys, go. Concurrent use of lithium, concurrent use of BZs, intracranial mass, seizure disorder, myocardial infarction 6 months previously. I don't see people answering, to be honest. Just pick something, just go with it. Trust what you speak. One more, I just need one more. Okay. All right. Yeah. 1 second, let me open for somebody the door. Yeah. Still asleep. No. I'm sorry, I'm back. Okay. So we have all answers. Robert Mugo, thank you. Sharon, thank you. Ian Day, thank you for answering. Elma, thank you. Thank you, Charles. That's what I'm talking about. Let's answer this question. Let's go. And that, if you, most of the time, if you speak are not the most correct answer, you're gonna remember this for a longest period of time. So concurrent use of lithium, is that contraindicated? No. This is what we do. Before you give an ECT, we tend to reduce the amount of lithium. So we try to go below the therapeutic index, and we're gonna talk about the therapeutic dosages that we want the patient to be on. So we reduce that dosage a little bit. Then, and there's one reason why we do that, because sometimes people tend to lose memory if you have high lithium in their blood system. So we don't stop them from getting ECT. We just reduce the dosage and then send them for ECT, okay? So, and they will be on lithium. So lithium is not a contraindication. What about benzodiazepine? The same thing. You don't want them to be on high dosages of benzodiazepines when you go to the ECT. But do we do ECTs with benzodiazepines on board? Yes, we do. Okay. I'm gonna skip C for now. Seizure disorder. ECT itself, it's a seizure that we give these patients. Okay. We just stimulate a seizure in their brain, and we treat them using a seizure. So a seizure disorder, I'm sorry, I'm biting my tongue. It's not a contraindication at all for these patients. Myocardial infarction, maybe if it's very recent, we might try not to go there with an ECT, but more than 6 months, we really don't care about that. The other thing you should remember, if you had a stroke is a cerebrovascular accident. What do you think? Are you gonna go ahead and do the ECT? If it's in the last 1 month or so, or maybe 2 months or so, mostly they talk about 1 month actually. You don't wanna do it. But if it's more than that, you will go and the patient can benefit from ECT. You don't have to restrict them because of 10 years ago, I had a stroke. Okay, but now you have mania, you are not able to, you are super agitated, and we are not able to control you with the medications that we have. So what do? We go ahead and give you an ECT. Intracranial mass, if you think about increased ICP, intracranial pressures, okay, these are patients you don't want to start an ECT. You don't want to create more pressure on that brain, okay? So C tends to be the correct answer at this point, maybe the most correct answer, okay? The others might be answers depending on how the examiner puts these choices out there. Unless you have any question about this question number 5, I'm going to proceed to the next question. Any question? Nope. Yes, no. A quick one is it a complete contraindication? So intracranial mass tends to be a total contraindication. If you have increased ICP, then you're not gonna go ahead and do an ECT. You're gonna try use other means to help these patients. Maybe polypharmacy, maybe add some more medications on board to help with this patient, maybe sedate the patient more or stuff like that. But as I thought last week or the week after, the week before, I remember telling you guys, like in acute mania, these patients, we give them antipsychotic, not a mood stabilizer. When they are very sick, we start with an antipsychotic rather than a mood stabilizer, okay? So I hope I answered that question. I think ICP is one of the biggest contraindication, absolute contraindication. You know, there are relative contraindications here, but absolute strongest contraindication. Look at the question tells you which of the following is the strongest contraindication to use of ECT. And I think this is all you need to know for that exam in terms of ECT, but you should know that ECT is used for several other things, including catatonia. So I want to explain something. If you see a patient posturing like that, like against gravity, they're like the way I just did for a few seconds, that's catatonia. And most of the time, those patients, we treat them with ECT. The other thing is a lot of agitation and you are not able to control those patients. Of course, major depressive disorder that is resistant to medications, we give them ECT. Across most other countries, not the US, if you have a patient with some schizophrenia that is resistant to other medications, sometimes we use ECT. But the best indication is mood disorder with psychotic features. If we have depression with psychotic features, this ECT is the best indication for that, okay? Yeah, so unless we have other questions, I'm gonna keep going. The patient accepts ECT stating that it will be a quicker way to death than the lingering existence, okay, she has on the inpatient unit. Which of the following is true? So listen to that statement. Let me read it one more time. The patient accepts ECT stating that it will be a quicker way to death than the lingering existence she has on the inpatient unit. Which of the following is true? Please give me the answers. ECT may be pursued now that the patient has given informed consent. Okay, informed consent should be questioned because of the patient's reasoning process. Okay, if the patient is under an involuntary psychiatric commitment, informed consent is not required for proceeding with ECT. D, decision-making capacity is typically compromised by mood disorders. If the patient's next of kin agrees to ECT, it's not necessary for the patient to give informed consent for ECT because of physician privilege. So guys, I see some answers, D. Any more, please give me more people. I need like 4 ways of just trying to answer. Sometimes when I see your answers, that helps me to kind of know how I'm going to explain this. So I don't care if you get it right or wrong. I really don't care about that. What I care most about is what are you going to benefit from today's discussion? That's it. So I see D's, B's, and E's right now. Any more? Okay, so let me start with A. ECT may be pursued now that the patient has given informed consent. Informed consent, that statement that you saw there, that's not an informed consent. This patient just said, just give me that one because it's quicker way to death. So this patient thinks it's gonna heal him, and he doesn't want to stay in the inpatient. That's not informed consent. And we can talk about informed consent, which is very common in the exam USMLE. Actually, we can talk about it right now. Informed consent should be questioned because of the patient's reasoning process. Okay, I'm gonna skip that answer. Okay, let's look at C. If the patient is under an involuntary psychiatric commitment, you know, informed consent is not required for proceeding with ECT. That's absolutely wrong. If we have a patient in inpatient involuntarily, still we need to ask them if we can do stuff for them. We can give them medications. Consent is a continuous process. It's not something like, okay, we're gonna put you involuntarily in the hospital. Actually, this is what we do in psychiatry. And remember this for your exam. When a patient comes in and we think that they are compromised in terms of decision making, okay, we write to the court and tell the courthouse, like, we need to hold this person for the next 2 days, maybe 48-hour hold, okay? The court will allow us to hold him for 48 hours. If he says he doesn't want to take medications, we do not give him medications unless he starts being super agitated, kicking staff members or kicking other patients. That's when we give him emergency medications like IM injections or stuff like that. Okay. Then if the patient decides to so sorry, I lost my thought process. My daughter is trying to talk to me. Anyway, if this patient stays in the hospital, still the patient is very sick and 48 hours are gone, we go ahead and file to have this patient in inpatient treatment. And we go for a court hearing, actually, where the magistrate will decide whether the patient needs medication. So go ahead and treat the patient. We have to convince the attorney or magistrate, the judge, sorry, we have to convince them that this patient is sick and needs treatment. So what do we do at that point? We go ahead, and when the judge decides that this patient can be taken care of and sends us the documents, we put some medications for the patient. We tell them, you know what? The judge told us we can go ahead and treat you, so you have no options. So at that point, we go ahead and give them medications. If they don't want oral, we give them IM injections by force. That's the only time we use force under the guidance. So D, decision-making capacity is typically compromised by mood disorders. Guys, this is a USMLE concept that you should know. We do not, as clinicians, as physicians, we do not we do not take care of capacity. Capacity is not our role. Capacity is for the judge to make. We don't make those decisions for ourselves, okay? So we can say the patient is compromised in terms of thought process or anything like that, but capacity that is for the judge to decide whether the patient has capacity or not. And this is a question that will be there in your exams. I can promise you, if you see capacity, that's not your role. You are a physician. Your role is just to treat, just to do a physical exam, see whether the patient is compromised in terms of decision-making, okay? Emphasize, decision-making, compromised. Insight, maybe poor insight. Judgment, maybe poor judgment. But capacity, that's not for us, okay? So that's wrong answer. If maybe not, let's say wrong, but let me say wrong because, to be honest, this is a very testable concept in the USMLE. Decision-making capacity is for the judge. If the patient's next of kin agrees to ECT, it's not necessary for the patient to give informed consent for ECT because of physician privilege. Again, so I know we are privileged to treat these patients, but if we don't give ECT because the next of kin said so, this is not the power of attorney. If the patient has IQ problems and has a guardian or somebody like that, the guardian might make that decision for them. If you have somebody who gives you that you write down that this person will make decisions for me, that is the case. But we don't, next of kin is somebody, most of the time next of kin, they take care of, maybe when you're dead, they can decide, they can give more issues to do with that, like decisions, help you with decisions, like your child, you die and they say you're going to be buried somewhere in this is how maybe you wanted to, or this is how you wanted to die or something like that. But you don't make those decisions using the next of kin. So the correct answer here is B. Informed consent should be questioned because of the patient's reasoning process. Okay, so we do not have an informed consent at this point. If there is something you should go home with, I think it's that question number 6. In terms of informed consent. Okay, let's look at number 7, unless there's a question out there. No question. Let's look at this concept of ECT. So today I was supposed to teach mood disorders, talk about paraphilic disorders, and also talk about eating disorders. So we missed out on eating disorders, but we're going to talk about number 7. We're going to talk about mood disorders and try to see if we can catch up next week and cover those things that I missed out. All the following is true of ECT, except over 2/3 of patients with mood disorders improve with ECT. Refractory or mixed mania response to ECT. ECT works faster than antidepressant therapy for MDD. Catatonia response to ECT. Borderline personality disorder response to ECT. Guys, go. Please, the faster I get 2 or 3 responses, the faster I go. That's a good question. What's the difference between capacity and competency? I'm not sure how to answer that question. I'm not sure if somebody else can really explain that. I'm not sure. I will look for that information. I know there's a kind of explanation I have on back of my head, but yeah, I'll look for that. So we have E's and C's so far. So E's and C's, okay. So yep, so C and E. So ECT works faster than antidepressant therapy for major depression. That's a good point. Let me see, just put this down. So, oh yeah, I think I confused that, Doreen. I think you're right. Competency is for the judge and confused is for, capacity is for us to determine. I agree with that. I think I confused the two. Thanks. It's good to clarify that now. Okay, so we can go ahead and talk about this question. So I see C's and E's as most of the answers. So ECT works faster than antidepressant therapy for major depression. That's correct. Usually ECT, the moment you start patients on ECT, they take 6 sessions, which you can do 3 sessions every week. And by the second week, you start seeing them smiling, you know, from major depression. So that's a correct statement. ECT works faster than antidepressants for MDD. Actually, they say ECT is the best antidepressant that we have out there. So refractory or mixed mania respond to ECT. Okay. So that's true. If you have somebody who, that's one of the indications to do an ECT actually. Over 2/3 of patients with MDD improve with ECT. That's correct. ECT is the best antidepressant out there. Catatonia, the way I was just hanging, posturing. And we can talk about catatonia for like 20, 30 minutes. It has a lot of things there. Catatonia responds to ECT, that's correct. So borderline personality disorder responds to ECT, no. So these borderline people, if you remember, if we talked about personality disorders, including borderline personality disorder, they tend to respond to therapy only. It's just their cognition, just trying to tell them, you know what, maybe if you, this is more of a personality issues, you know. Personality disorders, most of the time they don't respond to many medications. You'll see these patients in the hospital and you put them on tons and tons of medications and their symptoms are not improving. It's more of personality. It's not the real pathology that we're talking about, like MDD and stuff like that. So E is correct. So let's go to number 8. I'm gonna try, see if we can go all the way to number 10. The patient receives 8 bilateral treatment with adequate seizure duration. She has improvement in her suicide ideation and feelings of guilt. She continues to have anergia, anhedonia, poor concentration, and tearfulness. Managed care has denied further inpatient stay even after your appeal to the company. What is the most appropriate next step? Continue ECT as an inpatient and ask the patient to talk to the patient about the financial options. Discontinue ECT, initiate antidepressants. Discontinue ECT, initiate lithium. Continue ECT as an outpatient in combination with partial hospitalization. Discontinue ECT, initiate BZs. So any choices there? Any choices, guys? Kiprotich, Kiplagat, Yomune. Okay, so we have at least 2 people answering that. That's correct. So the thing is, if you discontinue, is the best antidepressant. So discontinuation, the 3 answers there that shows discontinuation, we do not discontinue because we want to do antidepressants, because we want to do lithium or benzodiazepines. Okay, so continue ECT as an outpatient in combination with the partial hospitalization program and home supervision. Okay, so let's do the last 2 questions, guys. Then we can catch up this next week, and I can let you know that we have other people who wants to teach you about these things. Unless there's a question about number 8, I'm gonna move down to number 9. The patient has made a full response and returns to your clinic. What do you tell the patient about her prognosis? Because this happened in the setting of your husband's death, you are likely to have further episodes unless you have a severe stressor. You are at significant risk for relapsing symptoms and must remain on medication to prevent relapse. You are at some risk of relapse and do not need long-term medications, but you should be aware of the warning symptoms. You are at some risk for relapse, but we can diminish your medication to the lowest manufactured dose so as to minimize side effects while protecting you from relapse. As long as you are compliant with your medication, you will not have relapsing symptoms. So what do you think? Guys, please give me 2 people, 3 people. We're more than 20, so I will look through the chat and call out people if I'm not getting people telling me the answers. Yep. Doreen, give me an answer. Grace, Ian, Elma, Irene, Kiprotich, Lynette, give me answers, please. So that's number 9. Okay, guys. So I want to start with the responses. I don't know, some of you say D, some of you said E, C. So let me start from the top anyway. So because this happened in the setting of your husband's death, we are unlikely to have further episodes unless you have a severe stressor. That's not correct. You know, this person, any stressor, most likely give these patients the disease. This is just like you were in some like this patient was to get these symptoms, but this stressor meant these symptoms come at this point. So are they likely to come back? Yes, they are likely to. You are at a significant risk for relapsing symptoms and must remain on medication to prevent relapse. Okay, I'm gonna skip that for now. So let's look at you are at some risk for relapse and do not need long-term medication, but you should be aware of the warning symptoms that may indicate that you are getting sick. So any patient who comes with bipolar disorder, we treat them for quite some time before we even think about changing medications, okay? So we will be treating this patient for some time and watching for these symptoms. It will not be very prudent for a psychiatrist or a mental health provider to just send a patient out there and they are not even, you haven't been told even they are on remission. You have to work towards remission, sustained, no symptoms for a long time. And if these patients want to go down, you want to taper the medications and see how they respond, okay? So you are at some risk for relapse, but we can diminish your medication to the lowest manufactured dose so as to minimize side effects. We don't do that. So look, you are at some risk for relapse. You're telling the patient, yes, you have the risk, okay? Which is true. Most likely this patient is gonna relapse, but we can diminish your medication to the lowest manufactured dose. That's not how we kind of treat patients. Like you wanna go to the lowest dosage to minimize side effects. We haven't been told there's any side effects anyway to start with. So you want to give patients medications and you want to put them within therapeutic dosages. And if for example, this patient ends up to be on lithium, for example, it's a mood stabilizer, the required range is between 0.8 and 1.2, okay, units. I don't remember the units at this point. So you don't want to go lowest minimum dose for you to treat these patients. No, you want to maintain them on that therapeutic dosages. What is the most likely lingering? So as long as you are compliant, let me see E. As long as you are compliant with your medication, you will not have relapsing symptoms. So that's not true. Sometimes you can be on some medications, but you can relapse still on those medications. And it depends on what is going on, the stressors that are around you. And it depends maybe if you're taking, maybe some people, you know, there's interactions with food, alcohol, whatever. So somebody might be, you know, taking the medications and they are taking alcohol or they are taking some foods that can diminish the effectiveness of the medications and they can potentially relapse. So B tends to be, I don't like the answer stem. And there's only one thing that I really don't like about that answer. It might be one of the best answers. You are at significant risk for relapsing symptoms and must remain on medication. It's true, you have to remain on medication. When you use the word must, I think sometimes I find it's not the best way of putting a statement, but it's true, the patient will need to be on medications to prevent relapse. So, okay. So, what is the most likely lingering side effects from the patient's course of ECT? Anybody who knows this? If you don't know, it's okay. I can go ahead and tell you guys. George said memory impairment. Anybody else? Memory impairment. Anybody else? Personality changes. Anybody else? Okay. So guys, this is a good question actually, because C tends to be the correct answer, to be honest. Most people talk about ECT and there's a lot of stigma out there that ECT is not good because you're gonna lose your memory. Is that the most common side effect? No. No. Myalgia, being tired, that's the biggest thing. When these patients come from ECT, after you convulse them, you know, seizures and all that, they get very tired. I've not seen bone fractures, to be honest, during my short career. I've not seen bone fractures, but I'm not sure if it's common out there. Maybe it's something that can happen, but usually it's a very safe environment whereby the anesthetist is there. There's no jerking movements like you throwing your leg to somewhere a big distance and there's some things that you can knock. The environment is pretty safe. So I'm not sure about bone, like if those can be there or not, but myalgia tends to be the most common. You can get memory impairment for sure, yeah. So usually it's like memory impairment is something that people get, but we try to avoid it, maybe decrease your lithium dosages and all those kind of medications, okay? So I know I'm on top of the hour. I'm sorry I lost my PowerPoints initially. I was a little bit mixed up in the initial setup. But you know, that's why we're here. I say we share information and we kind of tend to share it together. I don't want to take most of your time. I would like to go through a few things, eating disorders that I didn't talk about next weekend. And then I'm gonna go through all the other questions, like 2 or 3 more questions that we have. So if you guys, I don't know what is your suggestions, because I don't know if this should be the end or you want to do one more case, which I do have many other cases down here, but I don't know what the panel, what is the panelists think, what is the other people think. Any thoughts, Dr. Gichoya? Dr. Newsom? I think they went to drink. They went to drink coffee. Okay, you guys want to do 1 or 2 more questions? We can do that. Okay. I guess we should do that. All right. So we have Mr. Law is a 32-year-old attorney who has been in psychotherapy for help dealing with death of his sexual partner, Mark, and several close friends from AIDS. Most distressing has been the intellectual decline of his friends. Many quite accomplished in their respective fields. Family history is notable for senile dementia of the Alzheimer type in his mother. She has been institutionalized for the past 5 years. The patient connects his grief about losing her to augmenting illness, which has experience of losing Mark and his friends to AIDS. He is on no medication. There is no personal or family history of psychiatric illness. He drinks socially. There is no substance abuse. Although he engaged in the bathhouse scene in his early 20s, sometimes having as many as 4 sexual partners in one evening. He has practiced safe sex for the past 5 years. He does not know his serologic status. Mental status exam reveals a conservatively dressed man with a goal-directed, coherent, and logic speech. His affect is full, mood is depressed and appropriate to expressed thought. There are no delusions or hallucinations. There is no suicide ideations. At the time of cognitive testing 18 months ago, he was alert, fully oriented, and cognitively intact. Mr. Law misses several therapy sessions because of fever, sore throat, myalgia, and malaise. He completely recuperates, but becomes preoccupied with the fear that he has AIDS. In trying to assess how realistic his concerns are, you consider. So Mr. Law's concerns are realistic since this presentation is characteristic of syndrome that occurs soon after exposure to HIV. The initial presentation of AIDS is usually inexorable and leads to rapid deterioration, unlike these symptoms which have resolved. Mr. Law is among the worried well described in the literature. Mr. Law's concerns about the flu-like symptoms are likely pathologically obsessive. Mr. Law's concerns are likely somatic delusions, part of a depressive disorder. So what do you guys think? Is it a delusion? Is it a depressive disorder? Okay, yep. So A, Mr. Law's concerns are realistic since this presentation is characterized by syndrome. Even if we're talking about psychiatry, remember, if there's a factual thing involving HIV or anything like that, you need to do that first. You never say, in psychiatry, you never say, like somebody has a mental health illness, you need to look at the labs. Are they normal? Are they within normal or not? If it's HIV causing all these symptoms, you want to rule out HIV first before you talk about mental illness or anything like that. So let's look at number 12. Several months later, Mr. Law is confirmed to be HIV positive. He states categorically that he's not afraid to die, but admits to difficulty sleeping because it reminds him of death. He's concerned about possible effects on his memory and intellectual functioning. Given the nature of his job and the agony of having watched his others' deterioration from Alzheimer's disease, what are true statements about AIDS dementia complex, or alternatively called in the context HIV-related brain disease? So the presence of Mr. Law's defensive denial of fearing death argues in favor of intact cognition. You know, the appearance of ADC could herald a rapidly progressive downhill medical course in a patient like Mr. Law. Were he to develop ADC, initial symptoms could more likely be apathy or social withdrawal than psychotic ideation. So ADC cannot be diagnosed unless there are other systemic manifestations of AIDS. Motor symptoms are rare in ADC. So what do you guys think? Anybody else? Bernard, you have 2 answers. Oh, okay. Oh yeah, you just answered the other one. Okay. All right. So usually, I don't know, you guys, if you have read through this AIDS dementia complex, C tends to be correct. Were he to develop ADC, that's AIDS dementia complex, initial symptoms will be more likely to be apathy and social withdrawal, okay, than psychotic ideation. So psychosis doesn't present earlier. So you start having apathy and social withdrawal and such kind of stuff. Okay. I'm sorry, this question is not full of maybe psych related stuff, but let's look at the next. We'll stop at number 15, okay? So let's do number 13, 14, and 15, then we stop. Mr. Law wants to begin an antiretroviral immediately and is exacerbated when this is delayed by tests that waste my time. He scores 1330 in mental status examination. Which of the following is true? Okay. Once present, the neurological and cognitive abnormalities of HIV infection are resistant to improvement with antiretrovirals. ADC-related abnormalities on PET scans in HIV-positive individuals improve with antiretrovirals. Okay. MRI studies have proven most helpful in diagnosis of preclinical ADC. Mr. Low's normal mini-mental status exam rules out ADC at this time in his course. Okay. MMSE is helpful in assessing the personality changes of ADC. What do you think? I think Irene, you answered for number 13, I guess. Anybody else? Do we have people or people are gone? Okay. So maybe you guys, you might not know this. This might be a little bit tough question, but if you do PET scans, so look at B is the correct answer actually. Yeah, so B tends to be the correct answer. So if you have dementia complex related to AIDS, so on PET scan, individuals improve with the antiretroviral disease, okay? We don't use MRI to diagnose anything like dementia in ADC. If you score your mini-mental status is high, doesn't mean that you don't have dementia, okay? So the MMSC is helpful in assessing the personality changes of ADC. That's not true. Okay, let's look at number 14 and 15. Of the following, the most common, want to use it? Yeah, go ahead. Yeah, of the following, the most common early symptoms of HIV cognitive dysfunction is, I'm stopping in the next 2 questions. Okay. So most common early symptoms of HIV is what? Anterograde amnesia, disorientation, slowed mentation, language disturbance, psychosis. So guys, I can give you the answer. This is not what I wanted to cover for today, but anyway, disorientation, no, not it's not psychosis actually. The early symptoms, psychosis tends to be when you're very sick. If you remember, if you guys have taken care of psych patients, the HIV patients, they tend to have psychosis a little bit late. Maybe they can be depressed initially, but cognitive dysfunction starts from slowed mentation. Exactly. Okay. Then the last question is, in the approximately a third of HIV infected patients with CNS changes, which of the following is most characteristic in the postmortem brain? This is pathology, guys. This is not psychiatry. So let me look for my answer there. Even me, I don't know. So do you have cortical changes, prominent neocortical atrophy, vacuolar changes of the spinal cord? I'm not sure about this question. You know, I'm not, this is more of pathology. Let me just look for my answers. Any answers? Let me see.
So definitely it's 15, right?
Yes.
So it's not going to be CNS, right? They really don't get problems with CNS. So although I see like these probably are like those question stems that you need to do. So they don't get hydrocephalus really.
No.
I think it's going to be between loss of oligodendrocyte and neurons. That appears to be almost like MS. This vacuolar and relative sparing of the spinal cord. I'm not so sure about that.
That tends to be the correct answer according to my sheet that I have.
Yeah. Okay.
Yeah.
People are saying E actually.
Loss of oligodendrocytes and neurons. Yeah, I think MS might be
maybe patchy.
Yeah, maybe patchy and stuff.
We're misleading people here, but that's why for the last case we will start from there and have.
We'll start from there next time. I don't want to go in and just talk more about this CNS pathology that I really don't know much about it. So guys, I want to apologize for the correct answer I see actually. So vacuolar changes of the spinal cord. I don't know. I cannot comment much about that. Anyway, these are questions that I got from medical students here in the US. They are using to revise for psychiatry. And I know I haven't really looked through them as much, like to know.
Guys, remember Walter's PowerPoint crashed at the beginning of this talk, so he made a very good comeback.
Yeah, my PowerPoint crashed, but I had to look for something to do. But I wanted us to do some questions on mood disorders because that's what I wanted. And we just kind of did it in question number 1. So for those who have exams coming soon, you can send me a message or an email. And I can give you some content to revise for psychiatry.
And next week we still have psychiatry again.
Yeah, next week we're gonna look through this more, and I will make sure that I have my PowerPoint also for eating disorders, and I think partially paraphilic disorders. I kind of, when I was initially talking to you guys, I kind of mixed up 2 Fs, fetish and frotteuristic. And again, I want to remind you guys that frotteuristic is when you people touch or come very close to others, and fetish is when you kind of go ahead and use objects and stuff to have sexual arousal and stuff like that. So again, the other thing that came up was about capacity and competency. Yeah, so competency is for the judge, capacity is for us to determine decision. Capacity is more of decision making. So I kind of mixed up those words too. Okay, for today. So as I said, it's more of sharing information. It's not like I know it all. So you guys, I hope you got something out of this discussion today, and that should be the end with 20 after. So That should be the end for today. And after next week, we have an endocrine surgeon. She's doing her fellowship in Wisconsin. She's gonna be teaching endocrine pathology and physiology. So I'm gonna get in touch with her and connect her with Judy and Newsom so that we can go from there.
Walter, one more thing. Could you send the email, your email to me instead of everyone else?
Can you say one more time?
Type back your email, but send it to attendees.
Oh,
when you put your email, you sent it to me, not to everyone.
Okay.
They don't have your email.
Yeah. So yeah, anything else? Any other questions, guys, that you? Any other thing, Judy? Dr. Wawira?
No.
do you go by Judy or Gichoya? What do you prefer?
Judy.
Yeah, but as I said initially, patients want to be called by their last name.
Yes, so. yes. Unless someone corrects you. Yes. So yeah. At work, I'm Dr. Gichoya. Yes.
Yeah. So you're not a patient though, but yeah, can go with that. Thank you so much, guys. Thank you and have a nice time. Good night, wherever you are.
Yeah. Thanks for joining. See you next week. Bye. Hopefully some people are getting some vaccines. I see they're making it to Kenya.
Oh yeah, I saw doctors getting it.
That's fantastic.
Yep. Okay. Thank you so much.
Okay, bye.